we are very passionate about at CareOptimize. Capitation risk-based contracts, because finally payment models are catching up with what we all want to do at the end of the day, which is take care of our patients, both when they're well and they're sick. When they're well, to keep them from getting sicker; when they're sick, to get them better, of course. And for a long time in a fee-for-service world, that's been difficult to do. The only time we received reimbursement was when a patient was not feeling well and came in to see us. But finally, that model is starting to change. And today we'll be exploring the drivers behind that change, how we've been able to captivate on that, or capture that with our partner, managed healthcare partners in the CareMax medical centers, how you can go ahead and apply this to your specific region, your specific type of model, be it independent practice, specialist, primary care, qualified health center. Really, there's different opportunities that present themselves based off of your model and where you're located geographically in the country. So our agenda for today is we're going to go through and understand how this opportunity has presented itself and how health plans are seeing capitation and risk models, because that has changed, and understanding their point of view helps understand how you can get contracts and all in this world. And a health plan would be willing to hand over the money that they had kept on their side for so many years previously. Well, then to explain some of the nuts and bolts of cap, risk, percentage of premium, things like that, how to exceed in that model, and then, of course, how we can help. So a little bit about CareOptimize. So we've been around for 13 years. We come from a number of different companies and have brought our different skills and expertise together. We've got 150 employees. We're scattered all over the country. Our headquarters is down in Miami, Florida, where I'm located. Megan, who's helping me, facilitates out in California. We really believe that healthcare occurs locally, and the different regional dynamics within each area of the country really makes a big impact on risk opportunities, but as well as how you have to interact with your patients to succeed in these types of models. And so we purposely try to keep a very geographically dispersed team, so that way we can keep up on what's going on. We're agnostic with different systems. That's really not our focus. Our focus is helping your organization succeed. And again, these opportunities present themselves from PCPs, solar practitioners, large groups, specialties, FQHCs, a lot of universities we work with, PAs, MSOs, all that. So the way that health plans have make money really changed. And so, of course, receive a premium. It doesn't matter what type of health plan we're talking about. We could be talking about Medicare, Medicaid, or Medi-Cal if you're out in California, commercial, really the gamut of different payers, Obamacare, PACE. Those generally follows the same model. So there's a premium that's either coming from an employer, an individual, or a government agency. And oftentimes that premium is just adjusted based on the health of the patient population. And patient populations that are more sick and are identified as being more sick through different means. It could be actuaries, it could be documenting ICD-10 codes that convert into HCC codes that chart, or it could be other models. California, for example, uses medications to determine how sick a patient is. There's a risk adjustment factor that goes into determining what that premium is going to be. So in general, the sicker the population, the higher the premium should be. And oftentimes, the premium is also adjusted for quality. And that quality could be based off of a bonus that's coming from Medicare and Medicaid, or it could just be simply if low quality is being provided, that plan is going to their contract will get canceled rather, with whoever is paying that premium. That's how the plans are, of course, getting their money initially. Plans are now actually required by the Affordable Care Act to calculate what's called a medical loss ratio. And the medical loss ratio by the Affordable Care Act can only be 15 to 20% of the premium, how large the plan is. In most cases, it's going to be that 15%. That other 85% has to be spent on healthcare costs. So 15% can go into things like marketing for the health plan, claims, sound, activities, all that stuff has to come out of that 15%. The other 5% has to get pushed down to physicians, hospitals, ancillary providers actually providing care. And should that number drop below 5%, the plan actually needs to go ahead and refund that money, either to the entity that's paying the premium, or in the case of commercial insurance, is that check will actually go back to the patients in some cases. And that's why you might have seen health plans do things like, hey, all generics are free for the last quarter of the year, because they're carefully tracking that medical loss ratio, and they would rather give away generic drugs to get that closer to that 85% than go through the check, writing a check and refunding that money back to whoever's paying that premium. So Medicare Advantage is an easier one to talk about. This is a very similar model to what happens with managed Medicaid plans, PACE, and commercial plans. Medicare Advantage is nice because these are large, round numbers. Typically with Medicaid, the easiest thing to do is, unfortunately, you take off a digit. But it's generally the same type of model. So using Los Angeles County as an example, the base premium that Medicare is paying Medicare Advantage plans is $996 a month. And as we were talking about, that gets risk adjusted based on the sickness of the patient. So let's say there's a 0.8 risk adjustment factor based off of ICD-10 codes that have been submitted for that patient. There's an additional $797 a monthly premium that would be paid to that plan. And then there's a quality bonus. So let's say it's an okay plan, job on quality, not a great job, but they're going to get a quality bonus as well, and so that would be an additional $80 a month. So the plan went from receiving $996 a month in this example to receiving $1,173 a month for caring for that patient. And many providers look at those numbers and say, wow, we would love to have a piece of that, especially when it's based off of caring for patients when they're both sick and well. If you're working in a Medicare Advantage environment with a high percent of geriatric patients, a Medicaid or FQHC environment, these patients still require a lot of resources, even when they're not in seeing your physician for a face-to-face visit. And so being a piece of this $1,873 really will help your clinic do what your mission statement is. And as part of the Affordable Care Act, the health plan can only keep 80 to 85% of the premium. The rest of the premium has to go down and be spent on providing medical care. So for that example that we were talking about, that we were at about $1,800 a month in adjusted premium, they go ahead and times that by the 80%, $1,530 needs to be spent per month on medical care for that patient to keep that medical loss ratio in check. So the plans have gotten a bit smarter, and what they've gone ahead is said, well, we're in the insurance business. We know a lot about risk to organizations, and the best way for us to keep our shareholders happy is to get as close to that 15% that we keep as possible. Let's go ahead and take that other 85% and just downstream it to the providers. And the providers can go ahead and worry about whether or not those patients come or not. But we're going to get our 15%, and we'll be happy with that 15%. So to shift payment models. Fee service is what has been around forever. So a payment performed results in a claim that goes ahead and receives payment back for that service. Versus capitation is a flat amount per member per month, but all services within that clinic are taken care of. And then there's these risk percentage of premium contracts out there. And these come in a lot of different flavors: side risk, full risk, shared risk. We could spend a whole hour talking about just those items. But the easiest way to think about it is when you're a risk provider, you're now responsible for providing across the entire patient's care continuum and receiving a flat amount per patient per month. And so let me dive a little bit into the last two there. A couple of years ago, CareOptimize decided to partner with a company located out in Miami that owns 7 clinics that provide services for immigrant seniors within the community here. And those are dual eligible, meaning they have both Medicaid and Medicare. They come from places like Cuba, Venezuela, and they've resettled down in the South Florida area. And these patients require an incredible amount of services, of course, on the healthcare side of things, but also social services. These patients oftentimes don't have the capacity or the tools to survive in a major metropolitan environment, and that can be transportation, getting to healthcare places, getting to either the centers or outside specialists or to hospital services. That be taking care of their teeth. Dental's a big factor in patient overall health. Doing their hair, making sure that they actually are well groomed, having a hot meal a day, doing connections to EBT cards, different home health agencies, things like that. There's a lot that goes into caring for these patients. In an additional fee-for-service model, that wouldn't be possible. These patients would be pretty much on their own. They'd be having to connect with social service on their own, getting their own caseworkers, things like that. Florida is not an expansion state. Florida doesn't have the best caring for patients that there are resources available to them. And so the medical leaders went ahead and made the decision to, instead of billing fee-for-service for actual medical services provided, they made the decision to go ahead and go at risk with the plans. So they receive about 80 cents of every dollar that come in from the state feds or is paid by patients. And that money goes, of course, to covering the medical care, but also to make sure the patients stay engaged. So if you walk into a CareMax Medical Center office, 50% of the square footage is dedicated and looks like a traditional medical practice. The other 50% is all about keeping that patient happy, healthy, and most importantly, engaged in their health care. It's very easy as a senior that's sitting at home without financial resources to become depressed, to not have access to family, especially if you've immigrated from another place and you don't have the financial ability to call back home on a regular basis. And it's easy for these patients to sit at home, their diabetic feet get worse, they start to fall down, and that's going to result in hospitalizations for these patients that is not in the patient's best interest. They'll go down here quickly. It's also not in the system's best interest. The system does best when patients are as healthy as possible. CareMax Medical Centers dedicate that 50% of square footage to providing culturally sensitive different wellness services, everything from yoga to Zumba classes to dinos to pool tables. It really depends on the specific area in the city that's being served by the medical center. And patients are brought in using transportation to company transportation to keep them engaged. The patients think it's more of a community center than a healthcare center, and that's really part of the point. We want the patients to go ahead and come into those CareMax medical centers. There, of course, the staff is trained to keep an eye on them, get them over to the PCP if they see that the patient's not feeling well, if they come in with new bruises or something like that because they're falling, if they start to lose weight, things along those lines. And the whole point is to proactively work with these patients to keep them healthy. And so that's an example of how go ahead and shift your model from just seeing your patients when they're sick to really caring for the overall health of the patient, making sure that they stay healthy, which is, at the end of the day, everybody's goal. So ways to increase your income in these capitated and risk models is really straightforward. The plan to make more money, and you really should be receiving more money for additional documentation work, qualities, things like that you're doing already. And that's really what we find when we work with groups. You're already providing social services, either an official social worker or you just have defaulted to having to provide those services for your patients to get taken care of. You're helping coordinate care. You're doing referrals. You're doing authorizations. You're helping to get those patients in after they've been hospitalized. But in the fee-for-service world, you're not getting reimbursed for that. The plan's, of course, making more money as these patients are sicker, as you do a better job caring for them, and the quality scores go up. They're receiving that additional reimbursement. So the three big ways to receive additional income is first, pay for performance. That concept's been around for a long time, but remembering that the plans have to downstream 85% of that patient's premium to the healthcare providers. It really changes the way that you should be looking at things to go ahead and receive additional reimbursement for quality measures. Again, the plan's receiving additional reimbursement. They're keeping their contract year after year. They're heavily dependent on you as the provider to keep those quality scores high. You should be receiving either bonus payments or have that baked into a higher rate if you're doing a great job on quality. If not, we should be talking about the resources. If you're doing a good job on quality, we should be talking about the resources that the plans have available that they can give you, or additional funding that they can give you to go ahead and take care of those. Because again, if your quality measures go up, the plan's reimbursement is likely to go up as well. So we talked a little bit about this, but this is how plans receive higher reimbursement for sicker members. Now, the plans themselves can't submit that information. They can't document that information. That's solely dependent on the providers that are contracted with the plan, either MCP and specialty notes, hospital services, medications that are being prescribed. That all has to be incredibly well documented because it's going to be audited. We've all dealt with health plan audits, and that's because the entity that's paying them is going in and making sure that they're getting the appropriate, that there's the appropriate documentation to back up the premiums that they're paying. And that's your job as a provider to make sure that everything is documented. It's not the plan's job, and you're receiving compensation for that as well. Especially if you have an initiative around accurately documenting patients' chronic diseases, you should absolutely be getting additional reimbursement because your plans will be. And the final is management. So CCM is, of course, a big thing with Medicare fee-for-service, but just coordinating care on behalf of a patient is going to be helping the plan significantly, and you'd be additional reimbursement for that, even if it's not a Medicare fee-for-service contract. If it's a Medicaid contract, if it's a Medicare contract, you're doing service that helps out the patient, but also helps the health plan in reducing their overall expense. Should be compensating you for those services. And we've put there several care management programs. C seems pretty straightforward, but when you start getting into private pay or Medicare Advantage or Medicaid, that requires really negotiating with the plan to, one, show them the ROI, and two, that they can go ahead and downstream some of those cost savings to you. Managing unneeded costs. This is really, we're all in the healthcare profession because we care about patients and we want to see them be healthy and succeed. And one way to do that is making sure that the patients receive the appropriate care in the appropriate venue. So none of us want patients going into the emergency room and receiving services. When patients do that, costs are sometimes more than they would be receiving in a primary care setting. The quality care, they're squeezed in between patients that are having chest pain, things like that. And the quality of care is going to suffer just, remember, it's not a primary care office. But also, unfortunately, there is an element of some hospital organizations that prey on certain patients that have chronic diseases or low income, and they see them as a good revenue source, a good way to bring those patients in, and keep them for a long time, code them as having multiple conditions, and keep those patients. That, of course, hurts who's paying the bill, but it's also very, it's not conducive to a patient's overall health and well-being. So ways of managing unneeded costs. So the first is that you really need to make sure that when you do have those rare times that a patient is actually able to see a physician, the physicians are very busy. They're spending 50% of their time doing administrative overhead, filling out forms, working on claim denials with your billing department, things like that. So the amount of time they can actually spend with a patient is rapidly decreasing year over year. And those precious moments that you're spending with the patient face-to-face really to be leveraged to be as most efficient as possible. So you need to be using the technology that we've all been mandated to put in place, but actually changing it to be a benefit for your organization. So one of those is you really need to have quality gaps automated at point of care. It's a very big difference between somebody calling and telling a patient that they're due for a test versus the primary care physician explain to the patient face-to-face to an encounter that they need to go ahead and get that quality measure closed. Ideally, having the mechanism on site to actually initiate that process, be it radiology or a lab draw station, or at least getting a referral if that's what's needed. So make sure that you're accurately documenting all chronic diseases that a patient has. So if you're in a Medicare Advantage, Managed Medicaid, PACE, or social, that's a little bit more hit or miss. Documenting the conditions that a patient has on a yearly basis and putting together a plan of treatment is good medical care, but it's also very important to the plan's reimbursement and to your reimbursement. And really making sure that you have anything that's happening in the community, specialists, hospitalists, primary care physicians, making sure that's available at point of care. You've got to really protect those precious minutes. We've all invested in HR systems, and we should be putting those to use. There's also ways that can be proactively notified between visits. So a lot of what we've been doing is receptive health information exchanges is great, and if you can get one working for you, where you can actually go in and query patient information, that's going to be the ideal. That's how you're going to have, on the top bullet point, the most information available to your physicians at point of care. A lot of health information exchanges aren't really there yet. And as an example, we're using LA County as an example. We have the same thing in Miami County, down here in Florida. A lot of out there have decided to simplify a bit and say, why don't we just focus on hospital admissions and discharges, because that's when a patient's the most vulnerable. And check with your local HIEs to see if they have event notification. And this is an interface that you actually receive notifications within your EHR. We've turned them into secure emails, text messages, things along those lines to get the primary care physician and their support staff engaged in those crucial hours between when a patient has been discharged from the ER or inpatient and they're getting resettled back in the community, making sure that that's a smooth process, that they are scheduled to get back in. You have all the documentation of what occurred. It's a really, really great way for you to care better for your patients, but also manage unneeded costs. No one wants a patient to go in, have the whole experience of being in the ER, be inpatient, and then not the adequate support system or the knowledge of how to care for themselves when they get out and immediately have to go back into an ER inpatient setting. And everybody hates hearing this is you got to close the loop. When you're sending out for services, when you're doing referrals for diagnostics, labs, specialists, you've got to make sure you receive that documentation back. The patient's going through the effort to get it done. The employer is expending that. If you're at risk, you're expending that. You've got to make sure that that investment pays off so that way you're fully aware of what's going on with the patient so you can provide the proactive care necessary to keep that condition from getting more serious. The final thing, we chatted about this a little bit, but making sure that the appropriate use of resources is occurring. You really want to minimize the emergency room visits. You want to make sure that the patients are getting treated proactively. Going back to CareMax medical centers and that 50% of the square footage being used for non-medical services, It's really this last bullet point. So in the CareMax model, you want to see the patient as often as possible because just preventing one ER visit covers the cost of all those non-revenue producing healthcare services. And the model is based around you want to be your patient's friend, you want to be their support system, you want to be the place that they want to go, not just the place that they go when they're sick, so you can proactively have that patient come in and identify problems. You do want to ensure that you have some mechanism where you're scheduling by acuity. Patients that are recently discharged from the hospital, patients that have multiple chronic diseases, you need to have some way of determining that patient's acuity from the EHR and presenting that to your schedulers to make sure those patients get in, and that maybe your routine follow-up on a healthy patient has to wait a little bit longer. But getting that patient in, it's going to prevent them from either going to the emergency room or even worse, sitting at home and the disease getting worse, and then a small problem becoming a large problem. Co-advice call lines, so nurse hotlines, things like that, are incredibly important as well. Again, if patients reaching out and proactive needs help, you need to make sure that someone's available to answer that line. And the last is education. So making sure patients have what your model is. So, a lot of work that's done from on the care side is about making sure patients know to come to CareMax first, to call CareMax first, and get help with that 24-hour care line, things like that, rather than sitting at home and letting things fester and become worse. A lot of times it is go to the emergency room, and that's a perfectly acceptable answer, but that's something we want to have occurring versus, we see these patients that are diabetic that they don't feel good, they don't want to bother their doctor, and it just gets worse and worse. So making those patients know that, yes, you are there to care for them, and even though their doctor may be busy, you are available to go ahead and assist them in at least getting to the right resources. To make this real. So again, we're talking high level here because we've got folks on the call here that are qualified health centers, private practice, universities, hospital systems, the gamut. And it's difficult for us to speak specific about your model without understanding the services that you provide, what your payer mix is, and the area that you're located in the country. Our areas of the country that are more payers are more aware of how to engage with providers in a capitated or risk arrangement versus others that really fee-for-service is all they know, and part of it may be educating your local payers about how they can partner with you better. But if something that strikes an area of interest with you, then please go ahead and contact myself or Megan, and we'll go ahead and happily jump on the phone with you and just get an idea of your specific situation, and then how we could go ahead and help. And the first thing is if that continues is doing a readiness assessment, seeing where your payer mix is, seeing where your organization's at, and if this is something that you can even embark on yet. We do payer negotiations all day long. We do them for CareMax medical centers. We do them for some of our other groups as well. And it's something that we're very, very comfortable with. And a lot of that is because we do have access to so much data, both information we can pull from your systems as well as comparatives across the country, and the track record of saying, yes, this works. Here's examples of specific contracts that's worked. What we a lot is in these big nationwide payers that are divided up by individual markets. Sometimes we have to say, call Susie down in Miami, who sets these up all day long. She can walk you through how to do the process internally. We can help with technology solutions. We all HRs, we're required to. Let's make those actually work for us. So we have a quality module that Megan is actually our product manager of. And what's very important there is we're presenting gaps both as they appear in the electronic medical record as well as what the plan's saying, which is very important for keeping those scores high. Adjustment suspecting, and we do have the ER and hospital notifications that we've partnered with different HIEs across the country. And then finally, we would love to have you come down and visit our partners down at CareMax Medical Centers and see how they're doing things. Sounds a little bit too good to be true, but more than happy to walk you through these centers and show you the model. You sit down with the CFO, walk through some of their financials, and see how they've been able to capture additional reimbursement by doing what we all want to do, keep our patients healthy and out of the hospital. Megan, if you could go ahead and unmute folks. I'm more than happy to chat with people here. Also, I know in getting into detail, we would have to go in and discuss some more private information about your environment, so please feel free to contact us offline as well.